Good afternoon to everyone. Welcome to our webinar about MRI in preclinical oncology. We are getting started on time. Today's webinar is called MRI, going under beneath the surface in preclinical oncology. Before we start, I'd like to address a few practical matters. So first, we are recording this webinar and the presentation will be available to all attendees afterwards. Then, after the presentation, Peggy will answer a few of your questions. So if you have any, please type them in the chat panel. We will gather all the questions at the end of the presentation and Peggy will answer them to you. Also, if you are experiencing technical difficulties, please directly let us know in the chat and we will do our best to help you out. Finally, and before I move forward with the introduction of Peggy, we've prepared a series of poll questions that I will ask you all along the presentation. And I'm opening the first question right now, which is the following. So all done, launching it. Do you see the first question appear? What is your level of expertise with preclinical MRI? So I look forward to your answer. I'll leave it open for 30 seconds. Right, so it looks like most of our audience today say they are beginners, Peggy. I'm closing it now. Now, let me introduce you to Dr. Peggy Proven before we start. So Peggy obtained her PhD in 2006 in physics from the University of Grenoble in France, where she mainly worked on the development of novel MRI techniques to characterize brain tumor in preclinical models. Peggy joined Oncodesign in 2008 as a study director in the pharmacoimaging unit, and she's been participating to the development of our preclinical imaging platform. As a scientist, as a physicist, she supervises all our imaging equipment, data management, and imaging analysis, with the goal to always improve the throughput and the quality of our pharmacology studies. Now, Peggy, are you ready to start the presentation?
Yes, thank you, Krista, for the introduction.
All right, so I leave the floor to you. I'll come back later on for the poll questions.
Thank you. So the aim of this presentation today is to give you some to give you some information on how you can use MRI in your preclinical studies and how we handle MRI workflow at Oncodesign to improve our orthotopical follow-up. So I will start by an introduction on the orthotopic models and some basic principle of MRI, just to let you understand what you can see on MRI image and how you can do this. So subcutaneous models are widely used in preclinical oncology, but because they are simple to handle, but it is known that these models are limited because of no tumor, no microenvironment, and it happens that the response to treatment are different between subcutaneous models and orthotopic models. But in practice, orthotopic models are less used than subcutaneous models because they need more expertise in surgery, and the monitoring of this model are more complicated, and it's more complicated to handle. So our goal today is to show you that with an efficient MRI workflow, it becomes possible to follow your model, your orthotopic models. So Krista, I think you have a poll question.
Yeah, exactly. So I'm launching it right now. And the question is related to what you just said. So, have you observed similar differences in activity between orthotopic and subcutaneous models in your project? Tell us about your experience. So I leave it open for about 30 seconds, and we look forward to your experience. So it looks like most of the answers are going toward the, I don't know, I've never tested an orthotopic model. So we want to know more. Peggy, I'm closing the poll question, and we listen to you then.
So I hope you will want to use orthotopic models in your next experiment. But no, I will come back. To MRI, to introduce you in just a few words, I don't want to go into the physics of MRI, but just some few information to so that you can understand how MRI images are done, on how the contrast come from. So the magnetic resonance imaging is based on the magnetic properties of protons. So each proton has its own magnetic moment, and when you put these protons into a high magnetic field, they will tend to align along this magnetic field. But they will do that with a specific rotation around the axis and specific relaxation time that are called T1 and T2, that are very different along the axis of the magnetic field, that is T1, and in the plane, that is T2. So while doing this, it creates an electromagnetic signal that can be measured, and that is the origin of the MRI signal. So in practice, what you can see in MRI is mainly waters. That's the main component of the body, and you can also see lipids. And the intensity of the signal will depend on the density of the tissue, but also on the relaxation time, T1 and T2 of each proton. And these relaxation times are influenced by the environment of the tissue. So, for example, lipids or proteins have a short T1, while free water has a long T2, and air, bones, collagen tissue or liver has a poor signal in MRI because they don't have a lot of free water. So it's these organs are not very well seen in MRI. You can also use contrast agents to change the relaxation time. It could be a gadolinium complex like dotarem, gadolinium DOTA, or iron oxide particles that will have a different way of action. So in practice, you can change the contrast of the images by changing the acquisition parameters so that you can have images that are more related to the tissue of the different tissue, or more related to the T1 of the tissue, or mostly related to the density of the tissue, like in these images. So in clinical practice, they usually do a series of different images with the different contrasts to combine the different information coming from these images to obtain a complete diagnosis. In this example of a human brain, the T2 image will enhance the necrotic core here. The second image will show the edema surrounding the necrotic part, and the T1 weighted image done after contrast agent injection will show the lesion of the blood-brain barrier in the periphery of the necrotic area. With all this information, it could be concluded that this patient had a glioblastoma. In a more preclinical context, in oncology, we don't need to have a complete diagnostic because we know exactly the type of tumors that we try to induce. So our objective in these images is to obtain the best contrast between the tumor and the surrounding tissue. So we can adapt for each localization and each model the best contrast between T1 or T2, for example. And the orientation of the image with, for example, a different choice made between an image of the liver when with an axial image and a T2 weighted image, and a lung metastasis model where we will prefer proton density image in the coronal orientation. Now, when can we use MRI in a preclinical study? So we can start by the development of a new orthotopic model, and then we can use MRI to characterize the tumor development in this model and correlate this with human endpoints and other biomarkers. For example, in this model of glioma in mice, the follow-up of tumor development can be done every week, and we can see that the tumor volume is increasing over time and is well correlated with survival curves. And in this model, we can detect the tumor by T2 weighted MRI at early time points, 8 days after tumor implantation. And accurate measurement of tumor volume can be done after 2 weeks after implantation. We can also correlate the tumor development with detected by MRI with the apparition of over change in biomarkers, like in this model of liver tumors, where we can correlate the level of alpha fetoprotein in the blood with the apparition of the tumor on MRI. The level of alpha fetoprotein increased earlier than the apparition of the tumor on MRI, but we have shown that it's not always predictive of the tumor development. But when the tumor development is more important, the two parameters are well correlated, and both can be used to monitor tumor growth. Then, when you have a model that is well characterized, you can use it in an efficacy study. And first, you can use MRI to randomize your study based on the tumor volume. In this example, MRI was used at early time point to evaluate the tumor development in each mouse, and to determine if some animals have to be excluded from the study. For example, this mice with a higher tumor volume at this time, that has a development that was different from other mice, and some mice where no tumor was detected at this time point. Then the other mice can be put in different groups, and we can start a study with an homogeneous groups between groups. So this is an advantage of MRI. So in orthotopic model, one of the main problem is to know the stage of development when you start to treat the animals. So MRI can help you to exclude animal with no tumor or abnormal development, reduce the number of animals in each group because you exclude no-techs, and you also have a more homogeneous groups at the beginning of the treatment that will help to interpret results and statistics. But this is not always possible because you need that the tumor are clearly visible at the time of randomization. So it's not possible for all models, because if you you need also to randomize depending on the treatment duration, the rapidity of the model, and the mechanism of action. So if you don't have, you can't wait enough to have a clearly visible tumor, it won't be possible to randomize based on MRI. But you can use MRI in the follow-up of the the treatments, and you can evaluate the response to a treatment and compare between different treatments. In this example, it was not possible to randomize on MRI because the treatment started 2 days after tumor induction, so it's really too early to evaluate the size of the tumor. But two different MRI were performed during the course of the treatment to evaluate the response to the treatment. And at the first time point, the difference between treated and vehicle groups were already visible, but it was confirmed by the second time point, where no more tumor were visible in the treated group. In this other example of a bladder tumor model in rats, these images are more difficult to interpret. So here you have got the bladder of the rat, here the spine, and the gray part is the tumor part, and the white one is normal bladder part. So in this study, when the treatment started, randomization was not based on MRI, but an MRI done a few days after treatment start shows that the groups were equivalent at the beginning of the treatment, and after 4 weeks of treatments, we can see a difference between the vehicle and treated group, despite a big heterogeneity in the vehicle groups. So with the 3 time points of MRI, it can help to conclude on the efficacy and of the treatment. So at Oncodesign, to be able to do this follow-up of orthotopic models, we developed a fully optimized workflow. It starts from the choice of our MRI system that is fully automatic and that can be that is integrated in our boundaries, so we don't need to go to an external platform for MRI analysis. Each acquisition is adapted to the model, and we choose to have fast images. We prefer to have a quality of image that just can give us the good information in a limited time. And we also optimized the analysis process so that we can have analysis online. So that's with this analysis we can do randomization based on MRI, because we can analyze the data in the same day as imaging. So we have a high throughput. We can have image 4 to 10 animals per hour, depending on the model. I already talk about the online analysis, and then with this optimized workflow, MRI becomes cost efficient because we can have a MRI follow-up less expensive than adding some satellite animals for biomarker evaluation. So with this workflow, we can handle studies including up to 120 mice or rats, and use MRI for randomization and follow-up of treatment efficacy. The use of MRI in a study is also an ethical benefit, and because you can reduce the number of animals with a monitoring of the same animals over time, and it's also a refinement of your study because you have a fully characterized orthotopic models. So now let's go to the next poll question.
Thanks, Peggy. Yeah. So I'm launching the next questions. So the last question was, we asked you if you had experienced differences, and most of the responses were, I don't know, I've never used orthotopic model. So here comes the next one. Have we convinced you that MRI provides a simple and cost-effective solution for evaluation of your compounds in orthotopic models? I leave it open for a couple of seconds, checking if Peggy convinced you. All right, then, great job, Peggy, because most of the answers are yes. 88% says yes, we have convinced. I'm closing the poll. I'll let you continue.
So I will continue with some more information on MRI, because I only talk you about morphological MRI, but you can do more with MRI. As I explained at the beginning, we can have different contrast in images, and we can also do more because we can do functional imaging like DCE MRI that will follow up the contrast agents arriving into the tumor, and we can then do an assessment of tumoral perfusion, and we can also go more in beside a water signal and try to have information about the metabolism of the tumor. So just a few examples to illustrate this. In this study, we used MRI to evaluate the perfusion of a breast cancer model in nude rats, and to monitor the effect of anti-angiogenic treatments. We used randomization process to obtain a homogeneous group at the beginning of the study, homogeneous for tumor volume, but also for the perfusion level at the beginning of the study, just before treatment start. And you can see here that the groups were homogeneous at the beginning, and then we follow up the evolution of the perfusion into the tumor over time when animals were treated. So we can see that we always have in this kind of a subcutaneous tumor well-perfused rim of the tumor and a very low perfusion in the center of the tumor. And we maintain this in the vehicle group over time. But when treated with with ribulin, we obtain an homogeneous tumor for perfusion with a well-perfused core of the tumor, with an increasing perfusion in the core of the tumor, and correlated with a decrease of the tumor volume. So DCE MRI is well adapted to characterize anti-angiogenic drugs in subcutaneous models. As I explained at the beginning, we are looking in a MRI to the protons, and they are not only present in water and lipids, but they are also present in all other molecules. So we can with imaging, with MRI, go more into the details and have a look to the main components of the tissue. So in this example, in the brain, in a normal brain, you can detect different components like the choline, creatine, and acetyl aspartate, and some lipids here. Then in the tumor, you have a change in the composition of the tissue, with less creatine and more choline, and also a decrease in the N-acetyl aspartate in this tissue. And then you can follow up the effect of the treatment on the metabolism of the tumor. You can also combine the morphological information of MRI with the more molecular information from PET imaging, for example, with a radiolabeled compound that can be seen in a PET images, and you can combine this with the MRI to know with more precision where your compound is going. Is it going into the center of the tumor, or like in these images, more in the periphery? And if what are exactly the other organs where your compound is going? That is not possible with only the PET image. So so all of this is part of Oncodesign's pharmacoimaging platform possibilities with our partners of the PharmImage platforms. So we have two main class of imaging capabilities for following compound biodistribution with fluorescence, ex vivo autoradiography, and in vivo nuclear imaging and gamma counting, and the different modalities that allow to follow treatment efficacy. So I already talk about morphological MRI or functional MRI. We can also use bioluminescent imaging that will complete the information from MRI, in particular when you have disseminated tumor models that cannot be followed by MRI. Bioluminescence could be a good alternative to that. Or you can also use standard nuclear imaging tracers like FDG or MESO that will follow metabolism or hypoxia. So to conclude, the orthotopic model are interesting model because they are more complex and they can be more relevant to evaluate therapies with more interaction between a tumor and the microenvironment. It's notably the case in immuno-oncology studies. With a completely optimized workflow, MRI becomes cost efficient and could be could add value to your efficacy studies in orthotopical model. And you can also go more in details with MRI to evaluate the mechanism of action of your drug for angiogenesis or metabolism, for example. So thank you for your attention, and if you have more questions, you can contact us via the imaging team email or meet us in different congress, even if it will be virtual this year.
Thank you, Peggy, very much for your presentation. So, as Peggy said, we'll be going to the EANM annual meeting, so virtual this year, and to the targeted radiopharmaceutical summit. So that's October and December this year. We will be there with our team and also giving presentations at the TRP. So we really looking forward to be there and to meet you there if you are joining. Peggy, we have a Q&A session coming up.
Yeah.
I already have two questions for you that came up. So first one that I received is, have you already evaluated PDX, so that's patient-derived xenograft models with MRI?
So yes, Oncodesign has a lot of PDX model, but only a few of them are developed in orthotopic models. But it's possible to follow this model, and we already done it on one liver model and one pancreatic model.
All right, okay. I have another question that came here. While I'm asking, I launched the poll question. So in the meantime, I'm also asking questions to the audience. So the question that came for you, Peggy, is, have you used MRI to evaluate combination of anti-angiogenic and immunocheckpoint therapies?
We don't have, because we don't have the opportunity to do it, but it could be very interesting to show to show how
Okay,
how the
okay.
combination change.
So by this, do you mean the opportunity didn't come up, and we do have the capabilities, or we don't?
We have the capabilities, but we were never asked to evaluate it by MRI.
All
But
right,
this is
okay.
possible.
This is something we can do. Okay.
Yes.
I'm looking. I don't see more questions. Feel free. We look forward to your question. It's the perfect time to take advantage of Peggy's expertise. Also, if you have more questions that will come up later, you have the email for Peggy and Peggy's group. The team of our experts in imaging at Oncodesign. Peggy, looks like I don't have questions. I don't have more questions that came up for you at this time. So thank you very much, Peggy, for this webinar. Thank you for taking the time to share with us. The presentation has come to an end, and if you have further questions coming up, you don't hesitate to send us an email. Thank you very much, everyone, for joining us today.
Thank you.
Thank you, Peggy. And yeah, have a great end of the day. Bye-bye. Bye, everyone.
Bye.